Hello, everyone, and thank you so much for joining us here today for our conversation, Understanding Hepatitis C, a panel discussion on transmission, prevention, and care. My name is Marissa, and I'm the engagement coordinator at Global Liver Institute, a liver patient organization dedicated to improving the lives of those impacted with liver disease and cancers. This webinar is part of our Tackling Cancer Disparities series, held in collaboration with the Health Council of South Florida, and the Southeast Florida Cancer Control Collaborative. Pass it over to Vicki to introduce herself and her organization.
Thank you, Marissa. So a little bit about our organization. The Health Council of South Florida is a trusted regional organization which is dedicated to improving health and wellness in both Miami-Dade and Monroe. Here in Florida, for over 50 years, the HCSF has provided unbiased health data, strategic planning, and community service, while also fostering collaboration and advocating for equitable healthcare policies. While the Southeast Florida Cancer Control Collaborative is a voluntary network of healthcare providers, community organizations, and advocates working together to reduce the burden of cancer across Southeast Florida. It's supported administratively by the council, and it promotes education, advocacy, and research to improve the access to cancer care in our region. So thank you once again for all of you being here. I really appreciate it.
Today's conversation will focus on hepatitis C, how it affects the liver, and how we can achieve hepatitis C elimination. We are honored to be joined by three fantastic panelists who will be sharing their perspectives and expertise on this important topic. Today, I'm delighted to welcome to the panel Jessie Powell, a physician assistant in the gastroenterology department who specializes in the treatment of liver disease, Clayton Ruley, the Director of Diversity, Equity, Inclusion, and Harm Reduction at the Community Liver Alliance, and Arlene Mahoney, Executive Director at the Southwest Recovery Alliance. Thank you to you three for joining us today. We're really glad to have you here. I want to start off this conversation with just giving you a chance to introduce yourself and your experience in the liver space. Jessie, I'll pass it to you to go first.
Yeah, hi. I'm a physician assistant. I work at a safety net hospital here in Minneapolis called Hennepin Healthcare. I've been working in the liver space for about 17 years now, taking care primarily of just patients with liver disease. And I also do a fair amount of grant work and research around hepatitis C equity, access to care, where we do some outreach screening and treatment out in the community. And then I am the medical director for viral hepatitis ECHO, we call Minnesota Community Collaboration on Viral Hepatitis, where I train providers in the community and others how to diagnose, manage, treat, link patients to care with viral hepatitis.
Amazing. Thank you very much. Clayton, I'll pass it over to you.
Thank you so much for having me. I recently got a new title, so let me read. I'm the Director of Strategic Initiatives, Mission Advancement, and Impact at the Community Liver Alliance. Community Liver Alliance is a nonprofit based in Pittsburgh that does all things liver, education, advocacy, and collaboration. We try to be a hub to various liver organizations, patient groups. We really believe, as my CEO, Susanna Mazzara, says, that often that we are truly stronger together. And so we try to be the cog in the wheel for larger progress when it comes to improved liver health and fighting liver disease. As far as my experience with, liver health, it started with working 15 years at the local syringe service program in my hometown of Philadelphia, where I'm based remotely. I worked at Prevention Point, Philadelphia for around 15 years, doing a host of services from free medical clinics, MOUD, MAT clinic, drop-in center, meal service, mail service, syringe exchange program, pretty much everything and anything that involved helping our participants, our clients, as my friend Ross says, our sunshines, to have healthier outcomes, both physically but also mentally. And so harm reduction is a big piece of the work that I've been doing for the better part of 20 years now, almost 20 years now. I want to say 2007 is when I started in harm reduction. And yeah, that's a little bit of my background. Thank you for having me.
Thank you, Clayton. And Arlene, last but not least, I would love to pass it to you.
Hi, yeah, thank you. My name is Arlene Mahoney. My pronouns are she, they. and I run a lovely grassroots harm reduction organization in Phoenix, Arizona. I'm also a social worker, and I'm a person who navigated a system that held an ethic of punishment rather than an ethic of care. So I am dedicated to changing those systems through practice change and systems change, and I get to operationalize that through my role as the executive director of Southwest Recovery Alliance and then also a community advocate. I'm also part of Hep Free AZ and also the community, what am I? Community co-chair of the Drug Research Advocacy and Policy Board in Arizona, advising on research coming out of the University of Arizona and their harm reduction research lab. And I'm really honored and happy to be here and excited to talk about harm reduction. Even though it's under attack, doesn't mean we won't stop doing it. We'll just shift, code switch, do what we got to because we're going to keep people alive and healthy. And
Yes.
that.
Well, to start off this conversation, I'd love to just go over what hepatitis C is for those who might not have the full understanding. Jesse, could you explain what hepatitis C is, how it affects the liver, and why it's such an important public health issue right now?
Yeah, for sure. Well, hepatitis C is a virus. It's an RNA virus that infects people's livers. It can be, it starts out as an acute infection where people may experience, symptoms like muscle aches, fatigue. They might even become jaundice, or they might experience very little symptoms or just like mild cold-like symptoms that they would never know that they even were infected by hepatitis C. Over the next 6 months, the body may clear this virus, but the majority, kind of 60 to 80% of people that are exposed to hepatitis C will go on to develop this chronic infection. So in those people with chronic infection with hepatitis C are not treated, then they can go on to develop things like cirrhosis, which is really advanced scarring of the liver. When those things start to happen, cirrhosis can lead to liver failure and result in the need for liver transplant. About 40%, 30 to 40% of people with chronic hepatitis C will develop cirrhosis within the first 20 years of their infection. And then those with cirrhosis are also higher risk for developing liver cancer, about a 3 to 4% annual risk of liver cancer for those with chronic hepatitis C infection. That could be increased. Any of these things could be expedited by certain variables, like if they also drink alcohol along with having hepatitis C, or if they have other liver diseases like metabolic associated fatty livers or steatotic liver diseases. And then there's multiple genotypes or strains of hepatitis C. So we go 1 through 6 on these genotypes, and then they even have subtypes of those. Those genotypes are not as important for like treatment, but we are seeing more and more genotype 3 infections amongst our newer Hep C populations. We'll dive into, and that genotype 3 infection does carry with it a little bit more risk for rapid progression, associations with steatotic liver diseases and cirrhosis and liver cancer. So kind of a caveat to the population that we're dealing with now. So huge public health issue, because viral hepatitis, or hepatitis C in particular, is the most common chronic viral illness in the country, and it has all these very significant downstream effects of liver damage, cirrhosis, transplant, liver cancers, death associated with it that will cost the health system, billions of dollars if they go untreated. So it's a growing population. We have seen a little bit of trending downward nationally on new cases, but we're not sure if that's a trend or just a little blip. But over the majority of this time, new cases have been increasing along with our opioid epidemic. And the amount of people that are getting new cases and getting treatment is abysmal. It's like around 15% of people are actually receiving treatment for it. So we have a lot of work to do to increase our uptake and not only identifying, but linking to care and getting these folks treatment that they deserve.
Yeah, absolutely. Thank you.
Mhm.
Building on that overview and focusing more on the real world exposure, Clayton, can you talk about how hepatitis C is transmitted and what are some common misconceptions or misunderstandings you see within the communities you work with?
Thank you. So hepatitis C is transmitted through infected blood. when we're talking about harm reduction, a lot of folks know that hepatitis C is a really high risk for a lot of folks because there's a chance that if you don't have clean equipment that people use to inject drugs or share drugs, that you are very likely to contract hepatitis C. But I would also say it can also come from sharing, like, you know, combs, or I mean nail clippers, razors, toothbrushes, glucose monitors. Although that's not as it's not as well known. Excuse me. There is a possibility for that. If you get a tattoo and the person doesn't use sterile needles, there's a chance that you can contract hepatitis C as well. There's a chance if you have a Hep C mother that you can pass it to a child if the person, doesn't get treated for hepatitis C. But mainly in the harm reduction space, we're very concerned with making sure that people have sterile equipment, not just the sterile syringes, but also the other materials that people use to inject safely, like making sure you have sterile cookers, making sure that you never share syringes, making sure that you use alcohol pads, antiseptic wipes. Um, you know, those are the major pieces. Making sure that if you smoke, that you don't share a smoking pipe with someone, because if you have cracked lips, and your lips have blood in them, there is a chance, although reduced compared to using syringes, but still a good chance that you can contract Hep C and other blood-borne diseases through even using a smoking pipe. So it's very important that, as Ariel mentioned, we continue to support harm reduction. It's also very important that folks continue to get what's needed out there to people, because it really is not just a potential change of livelihood or life, but it actually saves millions of dollars to be preventative instead of always being reactive.
Yeah, I completely agree. Harm reduction is a huge part of this Hep C elimination. Arlene, from your time at the Southwest Recovery Alliance, how do you see harm reduction, like forming connections, empowerment within the communities?
Yeah, so thank you. So if we zoom out and look at harm reduction programs, they are important because harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drugs. And in practice, what does that mean? Well, similar to what Clayton said, we are in the midst of a HIV, Hep C, and overdose syndemic, all public health crises. And people who use drugs experience an elevated risk within this syndemic. And due to stigma and criminalization, they are often excluded from formal healthcare systems. And a public health crisis demands a public health solution. And harm reduction programs operationalize that solution via a syringe service program. So a syringe service program, or SSP, also known as a needle exchange, is a evidence-based public health intervention associated with significant reductions in Hep C, HIV transmission, as well as overdose and fatal overdose. SSPs offer sterile injection equipment, syringe disposal, naloxone test strips, a lot of things that Clayton mentioned. And depending on the specific SSP model, they can also offer other integrated services such as like HCV and HIV screening with linkage to care, wound care, referrals to social services, SUD treatment, PEP and PrEP navigation, safer use education, and ultimately harm reduction saves lives and is a vital form of prevention. But then if you zoom in to a harm reduction program, you find connection. An SSP, when giving someone the tools, for example, a sterile syringe to protect their body from harm, says your life is worth protecting right now, exactly as you are. In a world that criminalizes and punishes people who use drugs, offering a sterile syringe without judgment refuses harm and affirms care and worthiness. It's more than prevention. It offers bodily autonomy, it honors bodily autonomy, and it's low barrier access to healthcare. So not only does it improve health outcomes, but it offers connections. And at the core, harm reduction programs recognize a simple truth: people deserve safety, health, and care right now. And it centers compassion, autonomy, and evidence. And it also strengthens not only individual being, but public health as well.
Yeah, thank you. The component perspective is super helpful. Now, yeah, Clayton.
Yeah, I just wanted to add, Arlene had mentioned evidence. We know this works not just anecdotally, but also, with, raw data. I wanted to bring up the George Washington study, which was a study that was done in Philadelphia by George Washington at the local syringe service program. That's how they termed it. It was actually Prevention Point Philadelphia because that is the only local syringe service program, or at least it was at that time. We know, especially, when it comes to HIV and AIDS and Hep C, they're very much oftentimes a lot of folks who are co-infected. And while this specific study, highlighted the HIV rate, I think it's still important to mention. In the period from 1993 to 2002, it was estimated that 10,592 cases of HIV was saved because there was a syringe service program. If you consider that at that time, the cost of HIV treatment was around $230,000, it was estimated that over a 10-year period, $2.4 billion was saved, or $240,000 annually, or 1.8 or 182.5 million after estimated costs for programming. So, you know, we know that, when you have folks who are, working to reduce harm around HIV, that Hep C is very much, aligned with that mission as well. And so, in that 10-year period, you saw that, it went from like 30 to 35% being infected with HIV down to 17% as well. So, you know, folks aren't just doing this because they want folks to use drugs, by itself. Even though using drugs, if that's something that you can do, we want you to do it as safe as possible. They're doing it also because it has impacts not just for the individual, but for public health and for the safety of everyone. You don't have to be in a space where you're doing harm reduction self to love someone who's doing harm reduction and receiving care at a harm reduction facility. So I just wanted to mention that. Thanks.
Yeah, thank you for bringing up that study. Super impactful. Now zooming out just to get a better understanding of the virus itself, Jesse, would you be able to walk us through the key differences between Hep A, Hep B, and Hep C, and why hepatitis C requires a different public health approach?
Sure, yeah. This is a very common question I get in clinic. Patients that have, may not even have a viral hepatitis or have one of the viral hepatitis is wondering what the differences are, and they are very, very different viruses, and the populations can be kind of unique. So I'll start with hepatitis A, which is is only an acute infection first off. So its transmission is mostly like we say fecal oral, so it'd be contaminated water or food supplies, like the most common way. You could also, we did here in Minnesota have like an outbreak that ended a few years ago of hepatitis A amongst folks that were injecting drugs and unhoused. So there's probably a mixed mode of transmission there between just like contact and then also maybe sharing and blood to blood exposure. So it can be transmitted in the community that we're kind of speaking to today, with like injection drug use and unhoused could be transmitted through shared equipment. But more commonly, we think of outbreaks of hepatitis A through this fecal oral route. People will get very sick. It mostly is like a very, like, kind of where we see very young or very old people that get it, that aren't, if they're not vaccinated to it, they will get the most sick, and we see the most risk for like death in those two groups. And then the rest of us may or may not even have symptoms. We may kind of like when I talked about hepatitis C, the same rules can apply, where people could have just very mild symptoms where they just feel a little bit yucky, to all the way to jaundice, major muscle aches, fever, chills, end up in the hospital with very elevated liver tests and concern for liver failure. And then they get over it. So 6 months later, or so, then the person is back to normal and they feel great. They go back to their life and they're now immune to hepatitis A and no worries about ever having to experience that again. And with hepatitis A, just shout out, there is vaccine for it. So we hear, should be vaccinating everyone. There's, it's part of like childhood vaccines, but, who knows what the government's going to say on those. But for all of us that are on this, webinar, we should be vaccinating everyone for hepatitis A, regardless of risk factor. It's easy to prevent. So in 2-shot series 1, and then 6 months later is the second one. So B and C are the two that can become chronic infections. So when we think about, we kind of been talking around it, but hepatitis C typically nowadays is like we're seeing predominantly amongst folks that are using drugs. And in the past, it's been, there was it was due to due to blood transfusions, because we weren't able to screen for hepatitis C in our blood pool until 1991. So the baby boomer population had the highest rate of hepatitis C, and they predominantly got that through exposed blood products. But they also could have got it through all the different ways that Clayton mentioned too, with tattoos, or it could be drug use, could have been anything. Dentists weren't wearing gloves back then. There's all kinds of, the army or military would vaccinate with air guns, and they've been linked to spreading Hep C through their immunization, like group immunizations when people were coming into the army or whatever. So there's a whole host of ways they could have got it. We saw this huge mountain of hepatitis C. We now have these great medicines that people are probably all aware of. They call direct acting antivirals, and those cure people at almost 100% rates. And so we've been able to make a dent in that population, but now we're seeing a growth of population in our younger age groups from 20 to 40 that are using drugs. And we're seeing a growing number of hepatitis C amongst that specific population again. So when we think about hepatitis B, this is a virus that can be spread both through blood-to-blood exposure like hepatitis C, but also is much more likely to be transmitted sexually. It is a virus that is a DNA virus, so it's different than hepatitis C in that hepatitis B is a retrovirus, kind of like HIV, which means it can incorporate itself into the host genome, whereas hepatitis C does not do that. It just replicates itself within the cytoplasm of the hepatocyte or liver cell. So there's no integration there, which is one of the big key reasons why hepatitis C is so treatable and is the only chronic viral illness that's curable at this point. So hepatitis B, while it can be spread through blood-to-blood exposure, has a good vaccine for it. And here in the States, we've had vaccine rules for right at birth for many years, which is also being challenged now. Most of the pediatric groups in primary care are still focusing on birth dosing for vaccine, but we could see this change. But when we don't see a lot of acute new cases within the US because of our good vaccine policies. But so when we get our new hepatitis B cases into the US, or our states are predominantly coming from immigrants coming from endemic areas. So it creates a different population to identify for hepatitis B, primarily those folks that are coming in. Many of them aren't using drugs, or different groups that we have to screen in a different way than hepatitis C. One of the other differences between hepatitis B and hepatitis C is that Hep B is predominantly people are predominantly infected at the time of delivery or birth or shortly thereafter. When you're an infant, you almost universally, if you're exposed to hepatitis B, will become chronically infected. Whereas as an adult that's exposed to hepatitis B, around 95% of them will clear the virus on their own. Interestingly, like hepatitis C is the opposite, and where vertical transmission from mom to baby is possible, but it's a very low risk for around 5 to 10%, whereas like adults exposed to hepatitis C are almost, are much more likely to become chronically infected. The reason when we kind of look back at these populations and why hepatitis C is so important is it's more predominant here in the US. And the groups that we're trying to identify are much harder to reach right now. So someone with hepatitis B comes into my clinic, they're maybe from a different country or whatever, but they are accessing care for now. They have access to care. They're engaged in the health system in a traditional way. It's easy for them to interact with me. But people with hepatitis C, the new cases are often people, again, that are unhoused or marginally homed. They're young, they otherwise feel healthy. They, often are using drugs. So it's very hard for them to function within like our traditional medical model where they have to be at a clinic at 8:30 in the morning for my visit. And if they're 5 minutes late, the front desk isn't going to let them see me or see the person. And, they need a different kind of care delivery. And like what we really focus on in our echo and like what my goal is to try and make that access different. We need walk-in spaces. We need outreach where people are being treated in the community. We need to partner up with SSPs to do screening, linkage to care, treat at the SSP if we can, med lockers at the SSP so we can just drop off meds for people and they can come pick them up where they're at. It's a completely different idea. We need these kind of co-located clinics. People are familiar with Dr. Martinez out in Buffalo, who does like La Bodega Clinic, where they do their hepatitis treatments, where they have HIV treatment, primary care, addiction. We got to engage the community in a different way to access people with hepatitis C and make sure that we're doing our part to ensure they get access to that treatment and care. So completely different way of looking at medicine, I think, when we're trying to appropriately address people that have hepatitis C. Yeah.
Yeah, absolutely. Access to care is such an important piece. Now, shifting from that back to the advocacy and awareness of hepatitis C, Clayton, why do you think hepatitis C is overlooked with communities? And what from your time at CLA have you found to be the most successful in raising awareness and advancing healthcare?
I think that a lot of folks, a lot of times, don't gravitate to hepatitis C because of its mode of transmission. A lot of folks don't feel like they're personally affected. They, particularly in communities of color and other marginalized communities, a lot of times don't get the same level of outreach as what people would consider a typical like intravenous drug user or someone that's from a different, high risk or neighborhood that is dealing with a lot of high risk. I would say whether it was my work at Prevention Point or my work in Community Liver Alliance, one of the most important things you can do is what Arlene mentioned, is build connections. Um, Folks, unfortunately, have experienced, I think, being used as pawns for research and for testing and for healthcare in the past. So, it's up to us as providers of service on all levels, social services, also medical services, mental health services, to, help break down the barrier, which a lot of folks will put up to protect themselves and protect their family. Outreach is really important, but it can't feel like direct outreach for one specific, topic or cause all the time. I think folks like being able to come to spaces where they feel like they can be comfortable, be themselves, where they don't feel like they are stigmatized and shamed for what they're doing or what they're not doing. To see familiar faces when you're accessing your safer smoking kits or your safer injecting kits, to know that you can get tested, pretty instantly for HIV or hepatitis C, to know that there are other needs outside of the drug using or the sex work or other risky behaviors that you can receive help for, including housing, including clothing, including food, including um, a host of other things that are basically a part of the social determinants of health. I think is really important. I think organizations should try to be, as best as possible, a one-stop shop, or certainly work to coordinate with other organizations that are doing the work externally and building trust with them, and making sure that when they're sending their participants to that organization externally, that they have the same or as close as possible to the same mantra about how to work with people in a dignified and humane way, and not let it be as separated. Because when folks feel like they're being not heard and harmed, that's when they don't want to access services, and that's when you're going to see that gap in people accessing, the testing and the treatment for hepatitis C and other illnesses. And so engagement is really important, but it's not, just the fact that you're engaging, but how you engage and the consistency of your engagement, that I would say is the most important thing towards folks getting the help that we want them to get. And then hopefully that, obviously, most importantly, that they're trying to get.
Yeah, like you said, I think treating people as a person with dignity and respect goes a long way with any kind of disease outside of hepatitis C too. So for Arlene, how do harm reduction programs and clinical providers work to eliminate hepatitis C, and where do gaps exist? Jesse, feel free to hop on this too. I know you have the clinical perspective.
Yeah, so I'm probably going to echo a few things that Clayton and Jesse already said. But particularly when we're looking at health outcomes for people with Hep C and the progression to liver cancer, harm reduction programs function as a critical upstream intervention. Hep C is both preventable and curable, and yet people continue to die and suffer because they have been systematically excluded from healthcare based on the way they exercise their bodily autonomy outside of normative standards, meaning like injecting drugs or using drugs. So harm reduction programs, similar to Clayton said, like meet people where they're at. And what Jesse said, like they don't require a person to come into a clinic. They build rapport and trust with people over time, the people they serve. And SSPs are not only there to prevent Hep C, but they offer a pathway to diagnosis and a warm handoff to a provider for cure. So there are different models of care, so it can look different, varying on the SSP, the state laws, funding, things like that. But one critical component to working with clinical providers is they need to treat the person that they're treating with dignity and respect, because stigma is so pervasive when it comes to people who are living with Hep C. So we find it's really important to get to know the providers that you're providing the warm handoff to. Also, tons of structural issues, obviously, but some of the gaps arrive when individuals test reactive at an SSP is when they encounter delays to confirmatory tests or barriers to entering clinical care. Stigma, criminalization, I already mentioned that. Those are really things that are really important. And structural obstacles. So like housing, getting your stuff stolen. That's why we mentioned having lockers. A lot of people, like even if you have an integrated program with screening and linkage to care and delivery of medication, like a lot of people are just trying to survive. They have a backpack, they get their meds in a backpack, they get their meds stolen, and then insurance denies them being prescribed medication again. So we have to get really creative on ways to actually meet people where they're at and to navigate the structural barriers and the structural violence they're experiencing so they can access cure. So ultimately, we know that people who use drugs and are living with Hep C are systematically excluded, and we have to bring the healthcare to them. So integrating services, one-stop shops, and including working with providers actively is just like so important to elimination, because we can't eliminate it on our own. We need each other, and we need to build rapport with people whose Hep C we're trying to eliminate.
I just want to take a second and highlight this quote that Clayton just put in this chat by Jose Martinez. It says, meet people where they are and don't leave them there. I think that's super important and just relevant to everything that has been saying. So I know we talked a lot about reducing stigma and harm reduction programs. This question's for anyone. Looking ahead, what policy, funding, or system level changes do you think would make the biggest impact on achieving hepatitis C elimination?
I could take a stab at that quick if you want me to. It's big. There's so many things that need to change, I think, like to really do this the right way. But it's doable. I mean, we can see across the globe in Europe and other places that where they've had a focused effort, that they've been able to reach markers for Hep C elimination and are on path for 2030 elimination goals and things. So we can do it. We have we have the capabilities, but right now in the US it's so fragmented. And I think Clayton and Arlena both spoke to this, like there's different rules in different places, like even just looking at prior auths for like hepatitis C medicine. Some states have no prior auth, open access to care. Some have versions of prior auths. Our state here in Minnesota has gotten rid of the prior auth, but then each like provider of Medicaid, the way our insurance works here, is allowed to do their own prior auth if they want, but the state Medicaid said you don't need one. So then now we have this mixed bag of all kinds of different prior auths for depending on which insurance the person has. So it can be be time consuming. It can be a barrier still. I think when Arlene talks about bringing providers and people and SSPs in different places together, it's so important. And it's like right now we have mixed like opinions. I think it hurts me the most because I still hear providers talking about sobriety, like, requirements or or ideas around not treating people if they're still using, because what's the point? And it's just infuriating to hear that. But if there's one person in my group that says that, I'm not, and they just refer to the group and not to me, then like all of a sudden Hennepin has a perception of like not being someone to treat. And I think that's we as providers have to break down that barrier, and we have to be as together on our own together on our model of treatment and like ideas around access to care. So I would say, ideally we get the federal government to decriminalize drugs, allow for safe use spaces where they're illegal right now. So we have a place where people can come and use safely. And then we would have increased funding for like test and treat models out in the community. So we could use like this new Cepheid machine where we can rapid PCR test. So we could be out along with Arlene working in SSPs, testing and then linking and providing treatment on site. And I think that would be the goal. And that's what's worked in other places where they have the ability to do a rapid test. They have ability to write a prescription right there, may even have the pharmacy on wheels with them, and they can start people on treatment right there, come back and give them a whole month, the whole treatment in one if they need it, or put refills in the med locker as we go forward. But we need a total paradigm shift on what we think how we approach people using drugs, and like how we access how we are having people access care, as far as like from going away from this traditional model to these integrated models or on street treatment models, so street medicine. Yeah.
I would jump in and say, I feel like, to Jesse's point, I think that we need to go with the, research, the science and data and what people are saying works, and let the only morality be helping people stay alive, helping people thrive. Um, if your morality says that, me dying isn't a big deal because I shouldn't have been doing something, that's not the morality as a country, as a particular state, as a municipality that we need to have regularly implemented. I think, like I mentioned earlier, it's not what we do, but how we do it. We need to like actually execute sound public health strategy. We need to recognize that we need people who have experienced the systems, as a person at the table, helping to hopefully implement those experiences, because they know better than most of us, what worked best for them. We need to get rid of an abstinence only model and understand that there is a spectrum of people who, will never not use drugs or never not engage in some risky behavior, but it doesn't mean that they deserve to die. And it is very much punitive if we are deciding that, just because they do, they deserve, to receive no care. We have the tools, as Jesse mentioned, in so many facets to help people not contract HIV, contract Hep C, to a wound care infection. We have the ability to get people into housing, into medical care, to feed people, but is the willpower around doing that, or is it trying to prove a point for, an era that actually never was, progressive or positive? The war on drugs has been a war on people. And I think that we have to like work to consistently give the message that it was that, but also there are strategies that have worked everywhere it's been implemented. We just have to like come out of the box of, this country being anti drugs, anti this, when we know that that's not true. So, we need to not have medical providers calling people, addicts and junkies, although I think it's obviously gotten a lot better. We need to like make sure that community members know that as well. So it's very much a bigger conversation than even this time frame can, allow for. But I think it really comes down to how would you want your child, your parent, your, neighbor, to be treated as compared to how we're in many spaces actually treating people. Because I think one says, I'd like to be treated like a human being and treated humanely. And the other says, currently we oftentimes like treating people like they, are a leper of our society. And that's where, in many cases, that's why we are in the space that we're in, not just around substance use and people being unhoused, but, overall, in this country right now, we're seeing it more and more. So a little humbleness, a little kindness, I think will get us a long way. But certainly policy wise, just go with the data and the facts and not what your morality says or your, um, you know, let's just work on doing things in a way that is humane and just for not just some folks, but all folks.
Go for it.
So I think it was a World AIDS Day event in December that I was at, where I heard that hope is adversarial. And as public health is decentered, with this administration and harm reduction is under attack, we just have to keep moving forward towards elimination the best we can and continue or try to continue to adopt integrated care models. Also, destigmatizing Hep C. Every time you have an opportunity, you hear someone stigmatizing somebody living with Hep C or something about Hep C or a person who uses drug, it's an opportunity, a micro opportunity to change someone's mind and change the narrative. And keep bringing people living with and who have lived with Hep C to the table when we have these conversations and we build these programs, because people closest to the issue are closest to the solution, and we have to lift up the voices of those most impacted.
Yeah, agreed. I think all of you put a very complex and multifaceted topic into a very well said way. With that being the end of the questions, I just wanted to check in with all of you. If there's anything else that you want to share, feel free to use this time to do so. And thank you all so much for being here today. I can see the passion that each of you have for the liver space and the people in your community, and the people in your community are so lucky to have you there working for them.
I would just, say, to the naysayers of harm reduction and helping people who have less, were people more likely to receive care? Is it, in front of an abandoned, storefront? Is it on a church staircase? Is it in a park, or is it in a social service agency, or a treatment provider's office, or a medical facility that has, staffing that is understanding and kind, realistic, but not, anti-people? In my experience, harm reduction has been effective because the people that are working at those spaces are running through the walls for participants. And I think participants can see the genuine way that they care for people. We need more spaces like that, not less spaces. So if you want people to get the help that you say that they need to get, they're not going to get it if you don't want to, be preventative, and put the funding and, the compassion into the services that people, want to access. And like I said earlier, we need to definitely work towards understanding that just like you're going to have people who, drink, and just like you're going to have people who like to skydive, and people who like to drive cars, and people who like cooking food and it gets hot in the oven, like, harm reduction is a part of a larger process of risk reduction. And we don't, tell people to stop doing things because they carry a certain level of risk. We work with people to do things as safe as possible. Why is there a difference with the populations that we serve compared to, other populations when it comes to risk reduction and harm reduction?
Yeah, absolutely agree. If no one has any further thoughts, just thank you all again so much for being here. We really appreciate it. And I will let you know when this is posted on our YouTube channel.
Thank you very much for having me.
Thank you. Thank you for having me.
Yeah.
Good seeing you,
Thank
Clayton.
you.
You
Nice to
too.
meet you.
Thank you. Nice to meet you, Jesse. Thank you,
You
Arlene.
guys.
Thank you, Vicky.
Yeah.
Bye. Thank you. Have a nice day.
Thank you. Bye-bye.
Bye.